and a warm welcome to the whole team of participants who are here. And today we're going to deal with a topic which is one of the cornerstones or important aspect of palliative care. And from what I get to know is all of you have been attending this session and you're nearly at the completion stage of this ICPM. So hope you've all obtained the knowledge that is required because knowledge is essential. Knowledge, skill, practice all together only will help anyone deliver the best care. And the main thing, what is all our aim is, do something in patient's best interest. So that is the aim and goal for all of us. Sangeet, before we start off, I just want to have few minutes just to get an idea how they're all, and then I will share one screen alone from my end, and then we will go ahead.
Okay, ma'am.
Okay, so from just I would like to get some information from all of you. Anyone already working in palliative care? If so, raise your hand or type in the chat or do something. See, nearly 16, 14 of them or some are there. How many, any of you working? No. So do I take that none of you are working in palliative care? If that is so,
Ma'am, there is a
there
response.
are some yes also. Yes. Just now I'm seeing. 1 minute. So 1, 2, 3, 4 oncology. At least 4 out of the 4. How many participants are here, Sangeet?
Today there is 16. There are 30 participants registered.
Okay, 16 of them. Of the 16, at least 4 of them are working. Okay. Why I wanted to know that was, see, some maybe already, as the 4 of you are who are working, maybe at least aware of some. Through these sessions, you would have known what is palliative care, definition, and things like that, which all of you are aware, because to know that is the cornerstone. It is any life-limiting or life-threatening. So oncology, non-oncology, all that you have gone through. So now we have come to a stage where end-of-life care is important. So we will go with the case discussion. But before that, I just wanted to share one screen. I'm just going to start screen share. Can you all see my screen?
Yes, ma'am.
Okay. See, this one slide alone, I want to take you through before we go ahead with the discussion, because these are called as important trajectories of dying, which, see, because to be aware of this will give you an idea what you need to know in the whole population that you're going to see. See, as I started off telling, you need to be aware of what is palliative care, what is terminal care, what is end of life care, and what is active dying. So I'll give you a nutshell information of all the 4 phrases that I used. What is palliative care? It is an approach to giving the best care to patient and family who has either life-limiting or life-threatening or any serious underlying disease. So that is general palliative care definition. Then terminal care will be someone who has disease which does not, that has got, who is having a disease has reached a stage where cure may not be possible. So in that stage, when cure is not possible, we in the sense, patient, medical fraternity, and the family, and everyone need to understand and accept that they have to understand that the inevitable, that is death, will happen. That is terminal care. Then end of life care is, again, see, terminal care, palliative care can go on for long period, months, years, anything. Then again, terminal care can also go on from like up to 6 months, 1 year. Then end of life care, that also varies from the whether oncology or non-oncology. Then you have that end of life care, as I said, from weeks to months. Then finally, active dying, when that can last from hours to days. These are the terms, because all these information you would have had all in your knowledge material that you would have got. So when it comes to final how death finally happens, these are the four proposed trajectories which you need to be aware of. The first one, where you see sudden death, you can see an like a vertical axis and a horizontal axis. On the vertical axis, you've got something called as performance, in which you see high, there is function or performance, and then on the horizontal one, you're seeing time. As time progresses, how the person or patient's lifestyle or the performance will be. So in this, someone will be having high performance, doing everything by themselves, and sudden death. This either as accident or a cardiovascular collapse. This only about 10% of population fit into this category. And then the second one, you see what is called as terminal illness. This cancer or oncology will come into this category. Roughly 15 to 20% of the population will fit into this. In this, if you see, they are having high performance, they're doing everything, suddenly diagnosis of malignancy or cancer, and then suddenly their performance decreases rapidly. So this is called as a waterfall effect. Yeah, just like any waterfall, they were doing everything normally, but suddenly because of the illness, they drop down from a very high performance status to a very low performance status. As I said, 15 to 20% of the population can fit into. And the third one, you see organ failure. Any non-communicable disease, organ failure, like cardiovascular, respiratory, renal, liver, any end-stage disease, end-stage organ failure will all come into this. So in this, if you see, the performance in one and two types, the performance was quite high. Whereas you see in this, the function is slightly lower. Why? Because the basic or the underlying comorbidity is bringing down that function status slightly lower. And then you see these are called as looping. See, each incidence or each loop is to be related or connected to their episode of some hospital admission or some event, which could be an infection or a fall, anything like that, or some problem with the organ failure. So each time they do recover. See, the dip is the stage when they are in hospital or going through the event, and then they recover. Each time they recover, but if you see, if you extrapolate that to the function line, every time it is coming down. For example, if we take the third episode, it is nearly 25 or 50% less than the from where they started. You have to just extrapolate that line to the vertical line. So this is something the patient, family, and doctors all need to understand, that the efficiency, that is the organ, is not able to compensate. So it is going into decompensation. Okay. So this one, again, 15 to 20% of the population can fit into this. And in today's condition, when non-communicable diseases are rampant all over the world, this is something which all of us have to understand, so that we have to understand and convey this to the patient and family too. And then the last one is frailty, where you have a gradual, very slow decline. You see, the function is way too low. People living longevity, that is the current condition in many parts of the world, where people live 80, 90. We in India also, all of you will be seeing patients who are 90-year-old, even 100-year-olds, you see. So very gradual decline, and it goes on for a longer period of time. Again, this 40 to 45 or 50% of the population will fit into this. So this is something which I wanted to convey and make sure that all of you understand, so that from here onwards, because this is what patients you're going to see. See, all of us go through all these things. All of you are seeing patients, okay? It's another skill you're developing. And palliative care as such has to be done by many physicians. Only specialists to do palliative care means that will not be the way forward, because it has to be integrated into every hospital or every practice. So that is so because see, for example, diabetic, hypertensive, or a patient with chronic congestive heart failure and things, everyone, any general physician will be seeing the patient, not only specialist. Maybe a COPD or bronchial asthma. In today's world, they all go to a pulmonologist. Okay, so in that way, everyone needs to be aware of all this. Anyone has any doubt in this, please do ask, and then we can go ahead with the cases. Anyone wants to ask any question or clarification? If not, I'll come back to.
Ma'am, I had a question about the frailty model. Is dementia the only example, or are there other examples that the frailty model will apply for?
Frailty, anything, any old age. Neurology, dementia is one of the things. See, someone like generally they might have been fit and well. They can have general aging, whole geriatric population. Dementia is one diagnosis framed. So many other things also. Generally, very old age person has a fall. So those frailty will fit in to any geriatric issue.
Thank you, ma'am.
Is that clear? Okay. Okay. In that case, we can go. If there's no more question, we can go on to the cases, Sangeet. Or anybody else wants to ask any clarification with what at present? Okay, then go ahead with the case, because with the cases, hopefully you all can discuss and bring up your views and opinion and then go forward from that. Okay, so here we have got a 78-year-old woman with stroke, hypertension, and type 2 diabetes. Okay, please listen to each word. That's why I am reading it slow and steadily. Okay, every word is important. This patient is cachectic. Basically, cachectic means who is already skin and bone, bed bound, and dependent on all activities of daily living. She's brought into the hospital with reduced urine output and reduced oral intake. Okay, and at that time of admission, she's been diagnosed with urinary tract infection, and already she has end-stage renal disease. Okay, and she's advised antibiotics and dialysis. This is the admission. What is the at that point of time? What is being told? And when this is told to the patient refuses, while sons want her to undergo dialysis. Okay. Now, this one, step by step, what are your thoughts? How will you want to take this case forward? I'll give you a few minutes. All of you think about it, and then we can go into the discussion.
And for this patient, maybe we can advise them for palliative care, since she is elderly, multiple comorbidities, poor prognosis.
Yes, very good. Exactly. So that's all. So we'll just give a minute more for the rest also to have a think about it, and then we will go ahead step by step what all needs to be done. Your thought is totally right. So, but then how do we go about?
Ma'am, it is very difficult to tell the patient and the relatives that the patient suddenly requires a palliative care. So, initially, I would like to admit the patient and start the treatment of CPR for this patient.
Sangeet, can we go on to that?
Sorry?
So that can you come out of sharing this so that I can see all of them?
Okay.
Hello?
Yes, please go ahead.
So, ma'am, what I was saying was that it will be very difficult to suddenly tell the patient and the relatives that the patient
See, that's
requires
why.
palliative care.
Okay, you go ahead and tell, then I will tell you.
So, I would first like to admit the patient and start her on treatment for urinary tract infection, and side by side explain to the patient the situation of the relative and also the need for palliative care soon.
See, exactly. That's why how did I start off telling? No, see, this patient, end-stage renal disease. So that is not that's why I know the person who is looking after my third graph, what did it show? So she's end-stage disease means she would have had these type of episodes many times. So the talking should start by the basic family physician or the parent team physician who sees this patient regularly. Okay, so that is why we are telling this has to be integrated. Not that suddenly you go say no one will accept, and it is not fair also to do that. Okay, and no one needs to accept. Like if someone is forced on anyone, will anyone take it up? No. So as Dr. Sharda said, am I right? Are you Sharda who spoke?
Ma'am, Shraddha.
Pardon
Dr.
me?
Shraddha. Shraddha,
Shaba.
Shraddha.
Shraddha. Okay.
Yes,
Shraddha. Okay. Okay. Thank you, doctor. So basically, the whole information has to be explained to the patient and family. What is the situation? What is her condition? What is end-stage renal disease? What is correctable there? What is not correctable there? So that's why this is a very ongoing process. So when the patient is seen by the physician regularly, when the urea creatinine has gone up and they would have done EGF or so many investigations are there, no? So they would have done everything. Not that no one stops doing, everyone does, but communicating, truth telling, it is called. So give realistic hope, not false hope. Don't say everything is all right when creatinine is 5.5. Is it okay to say that everything is all right when creatinine is 5.5? Tell me, if someone says that it's fine, please raise your hand and answer the question, why is it right? Or what has to be told? Next thing is, when creatinine is 5.5, what is that? As a physician, it's our duty to say. Anyone can unmute and say. Because without discussion, it's the whole point of these type of sessions itself is open for discussion. Don't hesitate to ask any question or clarify your doubts. It is better to clarify in this platform rather than have doubts when you have a patient in front of you.
Madam, I'm Dr. Annie here.
Yes, please go ahead.
You have already told in the slide very clearly that the patient is bedbound. She is elderly with comorbidities. And basically, she has been having quite a tough time. So she is refusing further treatment. But the relatives still want her to continue because of the emotional bond. So what I have understood from this is that, as you have told, that the family physician and all those who are involved with this patient should inform them, like the end-stage organ failure, how it keeps going downward. And doing further and further doesn't really make much difference to the patient's quality of life.
Exactly.
So once it is cleared with them, I think they will accept it so that her wishes also can be looked into.
Exactly. Thank you very much, doctor. Exactly. See, it is the love and affection which is blinding the facts. Okay. So there, our role is to explain what is end stage. See, that's what all this doesn't happen overnight or with 1-2 minute conversations. Okay. So that is why, as I said, no, when the detail the question what I asked, when creatinine is 5.5, what is that has to be told to the family or the patient, or maybe family and the patient?
Actually, I had a unrelated, related but slightly unrelated doubt. A lot of our patients, when they're in pain, they're uncomfortable, they will say, "Ki, mere ko marne do." Should we take that as the patient refusing treatment?
No.
Should we?
See, that is because there your job is to treat the symptom, treat the pain. When you treat the pain, totally the same patient will tell something different.
Yes, who are having long time symptoms, who've been coming to the hospitals a lot of times, they will be tired, and sometimes they will say this. Should we? When should we take this as the patient refusing treatment?
No. You see, first job is to explain everything and correct the correctable. Pain can be corrected, correct that correctable, and then wait and see what. So that's what, see, that is why holistic care, all through palliative care, what you've seen, total care, total pain, everything, there's something phrase used as total. So correct the correctable. If pain is there, yes, long term, no. So that is why the long term means you have to see the pros and cons, whatever has to be, what can be corrected, yes, you correct. What cannot be corrected, or when this, that's all. When creatinine is 1, if patient has only diabetes, we are not going to stop. We will do everything to see what can be done. When you get to a stage where it is not possible to correct, or when it has gone to end stage renal disease, for all these, there are assessing scales or index, by which you find out, like patient's age. There are multiple factors in all your information material you would have read. You would have had all those things. So there is something called as Walters index, in which you put all patient details, and then I calculate that index, in which it will help you to prognosticate what is the patient's condition.
Madam,
And
Madam, can I ask you a doubt?
Yes.
Madam, if I'm a pediatrician, so if the child is having end stage chronic kidney disease, with a creatinine of 5.5, should we offer end of life care, or should we continue with dialysis?
No, again, no, that expert nephrologist complete opinion has to be obtained. Okay, in any condition, you get the input from the specialist to make sure that the correctable cause, any correctable cause is there, you go and correct the correctable. If that correctable cause, we have gone past the correctable stage, then you have to sit and explain about palliative care. Then you have to go through everything. See, when your first decision has to be made as a collective medical decision about the condition, and then you come to the palliative care stage, where when it comes to palliative care stage, then you treat all the correctable symptoms, symptomatic care, supportive care. That means what? You don't stop doing anything and everything. He said the patient is in pain, so it means you have to give pain relief. See, generally, pain and breathlessness are the most important. 80% of your patients will be coming for either of them. So that forms nearly 80% of symptom care. So you have to correct breathlessness, and you have to correct pain, ease the pain, because that will only give quality. The doctor said, Dr. Annie, I think she said, you are going to give what is required for the patient, best supportive care, pain relief. So that is what you have to provide. And if you don't give that, how on earth you will get best quality of life for the patient? So relieving and correcting the symptom. It could be pain. Mostly, as I said, pain and breathlessness are the common symptoms. The next ones are, they can have nausea, vomiting. Then you have pain, total pain. These are all physical. Then social, psychological, spiritual, all those components of pain also. See, that like total pain or total care, no? Are all of you aware of the 4 components? Can one of you please repeat what are the 4 components of total care? Anyone can say.
Physical, psychological, spiritual, and social issues, psychosocial.
Thank you, psychosocial. Exactly. See, you're all nearly at the nearly completion stage. That's why I see all these four, no, you can put for total care, for total pain, all these components. See, one person, pain is one physical symptom. He may be the breadwinner, so he's unable to earn. So, financial or social. Then his son is a very young family he has, so he can't go to school because no one to pay fees. And then finally, oh, God has punished me because I did something wrong in the early part of my life. So that is, so I've put in all these are there for anything and everything, because every person, every patient has a person within. Okay, so all these will be running. You give, for example, you're giving morphine for pain relief, but if you're not going to ease his family burden or his child's needs, will he be happy with the morphine? He will be happy. Some amount of physical relief he may get, but still the pain will be more. But if you correct the other elements also, less morphine may work for him. Have I put things across so that you have got the point what I'm trying to say?
Yes, ma'am.
See, this is quite important. Okay, now we will come to the rest. What were in the case? No, like first was as Dr. Amy also said, no, she's already patient, is already cachectic, bedbound, dependent on all activity. See that stage, no, Dr. Amy brought it out very well. See, the family has love, but the family also has to understand what is best for the patient is what we have to say. Someone is unable to get up and do anything. So will she be, if it was any of you in that position, will you be happy to be so? Has anyone thought? See, always in this end of life care sessions, we always to us, see, as we say to the patients, no, has any one of you thought of what will happen or how is that you want to be treated when you get to that stage?
Madam, I think most of us would like to go away peacefully from this earth and not tortured within the hospitals. So if we know we don't have much time, we should be with our family, give supportive care, give spiritual or psychological, all these cares, because these are not going to be there in the confines of the ICU.
Exactly. Thank you very, very much, Dr. Annie. Because this is very important. No, like if my next question, what I was about to ask you, you also brought it up. Someone is in ICU. You all see this in your own families. Not that all of us have 80, 70, 90-year-old family members. So when one such person is in ICU, the in fact the same son who in this case who says wants to have everything done, son won't even get the opportunity to get near the patient. And if that patient dies, will he be happy at the end of it? So we are doing something so that neither the family is happy nor the patient is happy. So that is where in this stage always you have to have an important insight on the ethics. What are the 4 cardinal ethical principles? Anyone can tell me.
Non-maleficence, beneficence, autonomy, and justice.
Very good. Thank you, Dr. Abraham. Autonomy, beneficence, non-maleficence, and justice. Autonomy is freedom or independence. Beneficence, do good. Non-maleficence, do no harm. Then justice. Justice is a very strong word. Okay. Basically, what has to be looked into there is a just use of the resources, and in that context doing the best for the patient at the right time, and who deserves it, that patient gets the best. There's no discrimination. Discrimination is only a medical discrimination. For example, X will improve, X will not improve. Why? Because of end-stage renal disease will improve, or a fit and well who doesn't have any issue, that person will improve. So that is the wise medical decision. It's nothing, no other factor is brought into place into that. Okay, thank you, Dr. Abraham. So these 4 components have to be kept in mind, very, very important in all times. So coming back to this, to our case here, this patient is telling that she does not want treatment and the sons are it. So now what is one of the, what is the ethical principle coming in there? See, all of you should try to speak, because again, the person who speaks is going to get benefited. As I said, no, when a patient comes and sits in front of you, you have no other, this 15 members here to discuss. Okay, so nothing wrong. Again and again, I say there's because in these platforms, you're all doctors, all of you are facing the same thing. So feel free to open and ask and do things.
Autonomy,
In this,
Go ahead.
patient has the right to take decision, ma'am, in this.
Exactly.
And we have to respect the decision, and we have to make the relatives understand the patient's decision.
Exactly. Thank you very much. So here important is autonomy. Patient has the right, okay, to make decision for him or herself. Okay, but at that point, couple of things to be kept in mind. One is to make sure that the patient is compos mentis, or patient is completely clear, aware, can understand. So at that stage, as you explain anything to any patient, you have to explain and also get back from them. Have they understood what you're telling? Ask them to repeat in simple words and terms whether they've understood what you have said. Okay, so there that gives few things clarity. You have conveyed, patient has understood, patient has all clearly making the decision under her will, because she has understood. She is able to comprehend the situation. And then next job is to explain to the family, and then explain to them the condition. And then see, as I said, no, it's just matter of time. If you explain, give some time, they will also come to consensus, speak to the patient separately, family separately, then have both of them together, and then explain, so that they both also don't have it. See, the mother is telling, I don't want, son is telling, so they'll be having some rift. So that also has to be solved, and then make sure. If the patient is not in a condition to make that choice, then we'll have to see what will be the other things. Just few points if someone wants to add on. If patient is unable to make the decision. So the patient is like dementia, not here patient is awake, alert, everything. But if it was dementia, what will happen?
We should see if the patient has made an advance directive.
Correct. Okay, if there is advance directive or something is there, please, we have to make sure, because always whenever those things are done, the documentation is there, and then the next of kin, that is whoever is the next person for that patient, maybe son, daughter, spouse, partner, friend, anyone it could be. Okay, so whether they are already aware, and then if the advance directive, if there is no advance directive, in that case also the same. See, there's not many things to be confused at all. If you know things clearly, there is no confusion. Even if there is no advance directive, then also you follow the same thing. Next of kin will always be the next person to whom things to be explained. If that next of kin also is not there, in that case, always what is in patient's best interest. That is how. And then nowadays there is a board. Like every hospital or institution will have a committee. When such situations happen, there'll be a team with 2 or 3 senior doctors who will be a team on these type of situation. There'll be a committee or board which will make the decision. So everything is clear and everything is uniform or following one guideline only. Okay, So that is how. So if patient is able to understand and make a decision, fine. If not also, that is the position. And always anything in patient's best interest. But as soon as you explain everything to the family, that the renal disease is so bad that it cannot be corrected. And already your mother is in such a stage that she is unable to do anything. So she prefers to not continue with the dialysis. So that explanation. And main thing here is you have to tell them that we will still be with them, do all supportive care for the patient and family so that the terminal phase and the end of life care all will be taken care of, that there is a team to support them. They will only be worried if you say, oh, nothing can be done. And then what do? They're lost in the dark. That's not what you're doing there. Okay? So that is so important thing is truth telling. You have to tell facts and figures and then explain to them, and also explain that you are there, we're going to be with them, give them how to contact, and then what all can be done. As through the discussion we had, explain to them about palliative care, what all can be done, what can be done in hospital, what can be done at home. Not a must that the patient has to be in hospital all the time. If there is facility of home care team, because many of these patients, she's already bedbound, she can't be coming up and down every time. So she would prefer to be at home. And if you have a home care facility or service, that team can go see her and provide the service what can be given at home. Is that clear? Shall we go on to the next case then?
Yes, ma'am.
Sangeet, can we go on to the next case, please?
Okay, ma'am.
There, you put that case on, and there was one chat question on collusion. Collusion itself is a big topic. Okay, you would have had communication sessions on it. I will just give some information on collusion. Basically, it is hiding truth, or that is what it is. But again, that is also done out of love and affection. Okay, there, what is the main job is to explain the risk and the benefit of collusion. What are things that are lost by not telling the information? That also has to be said. And what are the benefits of revealing the truth? As we said, all this autonomy, the first important thing in collusion is patient has the right to know. If it was always tell, if they for example, the son does not want to tell to the parents, you can tell the son, if you were in your parents situation, what happened, and your father or mother might have some wishes to be done. They would want to finish whatever they wanted to do or something like that. And then main thing is that when these things are conveyed, and then and many times what happens, there may be some difference of opinion and misunderstanding, and they will be feeling left alone, they're not taken care of, someone is hiding. 8 out of 10 times the patient will be knowing the diagnosis or the actual truth. The family may be imagining or thinking that they are not. So all these things have to be explained, and then you have to explain the benefit of telling, and then the side effects of, or the not useful effects of not revealing the truth. All these, when it is said, then you have to put forth these things to both family and the patient. And then initially you may have to go, if you suddenly say, no, I will go tell, it won't end up in a nice way. So you will have to collude with the family, and then, as I said, explain all these to them separately, to the patient separately, and then bring both together and then solve the issue, and then that will be the better way forward. That is because, see, collusion as such is a full half-an-hour topic. We cannot do that also in this same discussion. Hope whatever I have explained might make sense to Yamini, I think, had asked about it. Okay. So then afterwards, finally, if we have time, we can go back into that. So the next case, what we've got here is 20-year-old boy who has metastatic osteosarcoma of the lower end of femur, and he has lung metastasis and anemia. Okay, or basically osteosarcoma with lung metastasis and anemia. He has a large tumor on his thigh and he's insisting on getting operated. Both parents and patient are adamant that they want the surgery done. What should the surgeon do? And read the case once again so that we can come out of the screen. And 20-year-old boy with metastatic osteosarcoma of the lower end of femur with lung metastasis and anemia. And he has a large tumor on his thigh. And as the tumor is large, he wants it to be operated. So parents and patient are keen on getting surgery done. What is the surgeon's job here? And main things, as I've said, to keep in mind. I'll give you a minute. All of you think about this.
Ma'am, maybe we'll tell the best case and the worst case
Just
scenario.
1 minute. 1 minute. As I said, all of you think about it and then we'll come into the discussion so that you put everything together. Always, just one more tip I'm going to tell you. Whenever any information is given, you think, absorb, take a minute, prepare or form an answer in yourself that what are the things I'm going to say. Put a structure to your answer and then speak. Not only for yourselves, even when you see patients or even you're conveying something to someone, at any point of time, those type of answering will make clarity and you need not speak too much. You will convey everything what is required to be said, and the other person who is receiving or listening to it also will know all the information that they need to know. Okay, so it's just a thing to be practiced regularly, so that will be helpful for you. Sangeet, we can come out of the screen now, please. Come to the that view so that I can. Thank you, Sangeet. Now, like, what are the important points in this case? First, just the case, what are the things, salient points everyone needs to know before we go into how the surgeon does, what are the ethical issues and things here?
Beneficence. Beneficence and autonomy.
Beneficence, autonomy. Beneficence, autonomy, and one more thing also is there.
Non-maleficence, we don't do anything that will harm the patient.
Okay, very good. And Dr. Surya wanted to say something. Can you say? Thank you, Dr. Swati.
Yes, ma'am. I would like to start from what the patient and the attenders knows about the disease and what they expect by doing this surgery. And
what they are thinking.
Yeah.
What they are thinking, they are telling remove. So
yes.
What do they know the big picture?
Yes, ma'am.
Have they understood? As I said, many times they might have just known osteosarcoma, anemia, lung metastasis. Well, have they understood what has happened? And what is, maybe his anemia, his blood count is 3 or 4, hemoglobin. Sorry, hemoglobin may be 3 or 4. So,
yes, ma'am, that is a possibility.
So those things, first making sure whether they know the correct condition of the patient. And as Dr. Swati said, here so many factors are there. That's why in that question, what the surgeon should do. So here, as I say, we have to do something called as risk-benefit ratio or benefit-harm ratio. What are the benefits? What are the harm that can happen here?
Ma'am, in this scenario, if we feel the treatment is futile, we are allowed to refuse to go for the invasive treatment if we feel the treatment is futile.
What do you say? If the treatment is futile, I didn't catch what they are willing.
We are not obligated to offer the treatment if we feel that the treatment is futile. Just because the patient feels that they want to do it doesn't mean the doctor is obligated to follow through with that if he feels that medically it is not a sound decision.
No, here, no, we have to give clear indication that the harm, non-malfeasance, that do no harm, no, that is more than the benefit. Non-malfeasance is more than benefit. So here, two important things, because all these four ethical pillars, no, many times can have a interlinking or query, like does autonomy overtake or does non-malfeasance overtake? In those type of situations and queries can come into anyone, because that's why no, medicine is not so simple and one size fits all or it's box standard. If it was like that, none of us will have any role. Okay, so there is so much of intricate importance in everything. Yes, all these, I'm repeating these four pillars because they are so important. Autonomy, beneficence, non-malfeasance, justice, and all these have to be done with honesty, dignity, truth-telling, and empathy. These are other four things also which have to go with it. So if you're not, you know that very well that this large tumor, anemia, so we may even lose the patient on table if you do something like this to the patient. Is that a possibility or not? If you don't tell that, is that fair on our side? No. The patient and the attendant may be thinking, because it's a large tumor, if it comes out, it may be better off for him. But so here, if the harm is going to be more than the benefit, so that's what is called as risk-benefit ratio, which you have to make a risk-benefit ratio and see always the benefit should be more. If the risk is more, then it is our duty to explain to them. So this is where, and in these situations, see the autonomy, someone may get like a query, or you said first patient's wish. Yes, patient's wish is that, want surgery. But if the harm, if you tell the patient that this may cause harm to your life, then the patient may turn and change their decision. So non-malfeasance overtakes autonomy also, because you cannot do harm. You should not do harm. So in that stage, it's our duty to say that even though you wish, but if we go ahead and do this, this can lead into this issue and affect your life. So then if you explain to them, then go back and give them the choice. Then they may come back and say, okay, I did not know that. Is that a possibility? Same, Dr. Abraham also said. So Abraham brought a point that no physician is obliged to do just because it has to be done. Okay, so that is where all these factors have to be kept in mind. Anyone has any different opinion or anything else somebody wants to add on to this?
I want to add one thing, ma'am.
Go ahead.
This patient, since he has large tumor, surgical amputation is one of the way of managing the tumor pain also, ma'am. And before that, we have to optimize his medical condition like anemia, and we have to give some time, and then we have to go ahead and do the surgery.
See, again, no, there are many, you can do palliative radiation. No, there are so many other things. You have to see, yes, you have to see something, what can be done to relieve. Lung metastasis, exactly. See, that is what I was also coming to say, and thank you. Because you have to look into everything. I know, like, as a surgeon, no, like you want to correct, but you also have to see whether they will be able to withstand the surgery with such bad lung metastasis, whether they will be able to cope with the anesthesia itself. So that's all. These are cases. No, you have to get more information. As I said, it should be a medical team decision, and everything has to be considered and see what is the best thing. So then as I said, pain relief can be done in many other ways. Palliative radiation can be done. The tumor mass can be reduced. So you have to see all options of supportive symptomatic management.
Ma'am, I think we need to know ourselves also when to stop doing, interventional methods, when we have to stop using it. We can't just keep on going ahead
Correct.
just because the patient wants. And we have to tell this to the patient and the patient's relatives also, because they are in a very emotional state. They feel if I do
Exactly.
this, maybe wo
They
bach
correct
jayega. But
everything.
yeah, we need to make them understand and also understand ourselves that when we need to stop.
Exactly. Thank you, Dr. Swati. Many times, no, it is the professionals themselves also have to understand that it's not failure. Many times the problem lies with the medical fraternity also. It's not deciding failure and the success here. See, the disease or the entity as such has gone beyond redemption. So that is why it's not, as I said, no, it's always a medical condition which has gone past correcting state. As I said, correcting the correctable stage has gone past. So that is why it cannot be done. So it is a duty for us to also understand, to know where. That's why it's collectively, this patient will be seen by the oncologist. So it should be a collective, multidisciplinary approach, multimodal approach. So it's not one. So that is why slowly these things have to be integrated in many practices and hospitals and services. And then, so it should be collectively made. Yes, it has got to a stage where it cannot be done. Don't think that we are not doing anything for the patient. The palliative care team can take over and try to ease all the symptomatic relief. So just by doing this operation, are you going to correct and you want to give pain relief? But at the same time, risk benefit or harm benefit ratio always has to be looked into. Okay, and then the last point, justice, which I've already said, no. For example, you have a correctable, that's what I said, correctable cause with a patient. For that person, you can do ICU and do everything. Or you have someone who has end-stage renal disease with malignancy, metastasis everywhere. If you have that patient and a young patient who can come out of ICU going on a ventilator, the young infection or pneumonia patient, for example, there's a same 20-year-old who has pneumonia, no other medical issue, and you get a 70-year-old who has all medical issues plus a end-stage malignancy. And what is that you have to see the benefit, who will get benefit. So that is where justice also comes into. Okay, so these are the main factors which you have to think into when you are going into any of these situations. So, and then on top of that, generally, this end of life care has like supportive care, what all you do at the stage of end of life care, and then active dying phase also, whatever symptoms are there, you try to correct. And then, for example, feeding is one of the, like collusion, someone asked, feeding is another thing. Always everyone is worried, and patient and family, mainly family, want keep. So in that point of view also, something what is important is that to be conveyed that feeding as such alone is not going to correct or solve the issue. So those times you have to take those situations you have to take time, explain to them, tell them when the body itself is shutting down, not able to take anything more. So just by feeding, you're not going to correct or reverse the problem. It is these things, again, it's again love and affection. So simple, like giving sips of water or through a spoon, something like that, rather than starting right you but end of life care and situation. So these again needs more explanation. You need to take some time, and then as the condition deteriorates, gradually information has to be conveyed, and then that is how you move forward with the general. And then in as at the end of life care as such, you have what sedation and things. So it's an entirety, like with the discussion, we just saw the important things. So the rest, all information you will be having in your knowledge and basic study material. Okay, and then on top of that, you also have to, the palliative care goes on with bereavement and post bereavement. In the bereavement, like at the time of active dying and also in the bereavement period, because grief is something also to be kept in mind. And all these have to be continued. Like, see, as you see in definition of palliative care, from diagnosis to after bereavement, that is what is palliative care. And in that bereavement phase, the grief also is to be taken care of, and you have stages of grief and everything to be kept in mind also. Anything anybody wants to ask?
Madam, I just want to ask one thing. In this second case, we have a young guy who has osteosarcoma at the lower end of the femur. Okay, there is damage and there is anemia, agreed. But if we can do an MRI and a PET scan, we will be able to make out the extent of the disease in the femur, and
exactly.
If we the patient, and also if we can give neoadjuvant chemo, if the limb is salvageable, if we can give neoadjuvant chemo, sometimes there is shrinkage of the tumor. So that we can look into that aspect because he's a young guy. And
exactly,
later,
that's why I said what did I say? Multidisciplinary. No one person, palliative care physician alone doesn't take the decision. Right. I started off telling palliative radiotherapy, no? So always because this patient, the surgeon, just to not to go ahead and go for surgery, explain everything, talk with the orthopedic team or the oncology team, do everything. So whatever neoadjuvant, yes, everything can be done. Is there a possibility of doing everything? Yes, very good. If some facility is there where everything is provided, no one should not get anything. None of us, I tell one statement, which I will tell before I finish. See, if something can be done, 1 minute, if something can be done, put 200%, not even 100%. Put 200% and do everything. Okay?
Right, yes.
And another stage where it cannot be done, there also put 200% and do palliative care. That's all. See, none of us are for or against anything. Okay, but do the correct thing. You're telling neoadjuvant is available free of cost in your institution for everyone, doctor?
No, ma'am. You have to pay for it, but we can give chance to the patient. That's
as I said, no, I will do 200. I'm not even a person who will do 100%. Okay, so
right.
And I think Dr. Swati was very clear. It has to be understood by the physician first. Where does Dr. Swati work? Can I know?
Ma'am, right now I don't work, but I was working with the Indian Navy for 21 years.
Correct. See, real. Dr. Anu Abraham has raised her hand. Can you unmute and speak what you want to say?
Hi, ma'am. I just wanted to inquire about a scenario that I was presented with recently. It was an elderly
can
lady.
You tell where you work?
I'm joining from South Africa. I'm in one of the academic institutes in South Africa. So I was I'm a geriatrician, and I've been also doing palliative care at the hospital for 2.5 years now. And so we were presented with this condition where there was an elderly patient with a form of neurodegenerative disease. We don't really know what it was, but it has definitely advanced dementia. And so she had a PEG incited at a private hospital, and the PEG had dislodged itself, or the patient pulled it out. And now she was in the ward with seizures. She had a VP shunt in situ for what is suspected to be normal pressure hydrocephalus a long time ago. And so she presented with seizures, and the PEG was, unfortunately, it came out. And now the situation is she needs anti-epileptics, which in our state hospitals, all we have is oral or IV anti-epileptics. So the issue was the family was keen to take the patient home, but obviously there was concerns about from the daughter's side that she wanted to feed her mother. It was unacceptable culturally for her to take her mother home and not feed her. So obviously we explained the consequences about PEG and that it's not life-saving. It has its own limitations. And the family was accepting that she is dying, but not feeding her was unacceptable for them. From my side, as a doctor from palliative care, my most concern was seizures. Because it's obviously distressing for the family to see the patients fit to death. Although it can be acceptable for others, but I didn't think for this particular family it would be accepting to see your mother have seizures uncontrollably. So without a PEG, I can't give her any oral anti-epileptics. In that case, I was caught in a dilemma. Do I put the PEG back? Where at least then we will all, the patient will get her anti-epileptics because there's no other route that we could administer anti-epileptics.
Can you give me some, like, how was the patient, what she could do for herself? What was her quality of
No,
life?
she was completely bedridden and almost in a vegetative state. She could open her eyes and she could focus on me, but she couldn't
How many
verbalize
years?
much.
How many years
She's
she's been
moaning.
in this state?
I think it was a progressive decline since 2016, and she's been kind of bedridden for a couple of months right now.
Okay, so I'll answer all the questions one by one. For the fits, per rectal. Per
Yes.
rectal is a route. Per rectal preparations will be available, and per rectal routes can be used. And per rectal routes, even midazolam, many things can be used per rectal, and that is one option for that. And then regarding feeding, already I told one point, and then there is another example which I'm going to give you, which may make more sense to the patient and family. See, the things you said already, progressive disease. Progressive disease, you have to explain what is progression, what is prognostication, how the disease is progressing. So will it come back or how will it go forward? And then when in that stage, the body gradually is shutting down. So because it's shutting down, it's shutting down, the intake or input may not have big benefit. Not because she's not being fed, it is shutting down. So
Yes.
this one has to be explained. And then for that, you can give a very good example, which we normally say. You have these parasitic plants.
Yes.
Just because these things, explanation will make more sense to the family. For example, you have a tree, you have a parasitic plant on it. So sometimes by feeding, only the parasite grows. The tree may be shrinking and going down. It may be just not even having branch or leaf or nothing on it.
Yes.
But the parasite on top of it will be healthy.
Yes.
So like that, only the physical body, maybe you're giving this food and things which might, but actually the disease per se inside is eating away. That is what is progression.
Right. Okay. Thank you.
So see, exactly, no, that's why I say these types of platforms, best for all of you to discuss. So it's not easy. And then you also have to, as I said, no, it is time consuming. And explaining to the family, because she's progressively getting worse, just by feed, you can still tell them, have her sat up. See, by these things, no dislodgement, there's no risk of, and for her already peg, you have to insert a peg. For inserting a peg, it's again not going to be easy. You have to get these so that all facilities you have to do, you have to have everything explained, and it is worth, again, see, what did I say? If it is correctable, do 200%. If it is not correctable, do 200% palliative care.
Yes.
Exactly.
What sort of anti-epileptics can we give rectally as a
See, again, so what is available in your place? See, I can tell 10 things, but it should be available in your. So talk to some hospital or pharmacy. Normally, suppositories are there, and also midazolam. Many diazepam, diazimals used to be called. They are all available, which can be used for rectal. Because status epilepticus is an entity for many specialities, and there are very many ways of treating it, and per rectal, because even in A&Es, when you work,
Yes, ma'am.
like accidental emergency, if no other route is possible, we can use per rectal.
Thank you.
Midazolam, diazepam, diazmils, it used to be called. So have a look. So those are the things. So have I clarified, and then explaining to the patient and family, and best is for them to take her home and do what is best for them. Hope I
Thank you
have
so much.
clarified.
Thank you.
Okay, so these are the important things, and then as I say, you read all the information material, whatever you have, also to complete, so that you have all information that's required. If there's no other query, I'll hand
Just
it over
one
to
thing,
Sangeeta.
ma'am.
Go ahead.
Ma'am, yesterday only I was listening to a professor from from Tata Memorial, and he said like 6% of families in this country, they go into poverty every year because they are given unnecessary treatment in
Yes,
stage 4 because of the
exactly.
treatment. So
That's why.
we
So
have to keep
I'm
that also in mind. Like we are saying
correct.
neoadjuvant therapies and all. If the patients, I'm going to prolong that age, the life hardly for 3 or 4 months because this person already has stage 4 metastasis. So is it worth,
That's what. See, many people. Thank you, Dr. Swati. Not that I think who brought up, was it Dr. Annie? I think who brought up about
Yes,
neoadjuvant.
yes,
Not
yes,
that
yes.
we are not. No one is. Don't think that we are all seriously campaigning against neoadjuvant. No, no, no. Science research is our, like, what to say. That's the most earnest wish. Okay, but that doesn't mean, see, you have immunotherapy also. What is not there? Yes, but is there evidence to say that it is going to be helpful for this particular patient? And is there evidence? So, not that you shouldn't bankrupt that patient, just you have the remaining family also living there who have to continue their life. See, doing no harm is our, if we do that, that is also negligence. Don't think I'm using strong words. Yes, true.
No,
And
no,
thank
that's
you,
not
Dr.
what I meant,
Swati.
ma'am. That's not what I meant, ma'am. I meant
No, no,
if it is okay with the family, if they have the
exactly.
resources, and the thing is such that it is feasible for us to go ahead with surgical intervention later after realizing the extent and everything. And if all these are correctable things, it's not that in a
Exactly.
way.
No, no, no. That's why. See, how did I start off? I
I know, I
started off
agree.
telling you not that none of us are against anything. You do a collective. That's why do a multimodal, multidisciplinary approach. That is the important thing. So everything has to be, if something, see, simple words, no need this hi-fi words, correctable. So not, then go for. So that's why not one person makes the decision. See, everyone may not be expert in things. That's why you involve the experts in each specialty. And as I said, nowadays you have committees in hospitals where they will have 2-3 people and put everything together and then move forward.
Right.
Is that clear?
Yes, ma'am.
That's all. It's a collective decision, work together, team working. That is what ultimately for all this, the center point is patient's best interest.
Yes.
We'll do anything and everything for the patient in his or her best interest.
Right.
And next thing, involve the family. See, patient, family. See, that's what patient, family, patient, caregivers. You treat them as a unit. That is the important thing. Okay, I'll hand over to you, Sangeet. Anything anybody else wants to ask?
Make one more comment.
Yes,
My
please.
point, ma'am, was that we are not obligated to do something just because the patient says they want to do it.
Correct.
If it is not in the patient's best interest, then we should tell the patient very clearly that we should not be going ahead with it.
Exactly. See, that is also our duty. See, there, no? So that's why I said, if you explain the risk and benefit, then they will understand, oh, the risk overtakes the benefit. So then immediately the same person will tell, no, doctor, I did not know that will happen. So don't do it. So who said I want it will say don't. So where? See how it can change. See, that's where conveying the information plays a role. Thank you, Dr. Abraham, too.
Thank you, Radha ma'am, for the wonderful discussion of this presentation. Thank you all for participating and discussing the topic very well. Let's see in the next session, which is the discussion session. Thank you, everyone.
Thank you, everyone, and good wishes and good luck to all of you. And one last thing, ideally, all of you, it will be better if you do some hands-on. In your, like, Pallium will be able to guide you to the various centers all over India on where you can do 5 or 10 days hands-on, because all knowledge will go better and far, far ahead when you get to see patients and see, for example, you all can visit Pallium for 5 days or 10 days and see how much inpatient, outpatient, home care, everything is provided. So that, because seeing patient and doing all this, everything, end of life care, when you see patients, when they have subcutaneous infusion and things, it will be very, very helpful and useful for all of you. Okay, thank you and good luck to one and all.
Thank you, ma'am.
Thank you, Sangeet.